Hi there. My name is Sanjeev Anand. I'm a knee surgeon at Leeds and I'm going to demonstrate knee examination today. Scott Huntley, who's a medical student, has kindly agreed to help, and Dave Ginty is taking a video with him. Okay. So, in any knee examination, I start with the patient standing and fully exposed, as Scott is doing right now. I start looking at the whole profile of patient. I want to see overall alignment. I want to see the level of the shoulder, pelvis, and of course, want to look at the alignment of knee both in the frontal plane and any torsional malalignment if there is present. We can see that Scott has got slight tibia genuvarum, which is physiological in his case. I'm looking at any muscle wasting, any scars, sinuses which are not there. Okay, just after looking at the front, I would get the patient turn. Can you get your turn face on that side? I'm now looking at knee from the side, and in this position, I'm essentially looking for any lumbar scoliosis, lumbar lordosis or kyphosis, and if there's any fixed flexion deformity of the knee or any hyperextension. Can you get your turn and face towards the window? Yes. Again, from the back, now I'm looking at the overall profile, looking at the shoulder level, pelvis level, any muscle wasting, and looking at the heel and flat feet. Okay. Normally heels are in slight valgus. Can I get you to stand on your toes? And as he stands on his toes, the heels are turning into varus, which is a normal position. You can drop your feet down, please. Okay. So next is I'm going to get Scott to turn around and face me, please. So if you walk gently towards me and then walk back take few steps towards the window, turn around and walk back, please. So I'm looking for if there's any varus thrust, or if there's the abnormal gait in terms of antalgic element to the gait. Okay, that's fine. So he's got a normal gait. So next thing I want to do is I want to get you sit here with your legs hanging down. So after standing, I'll get the patient in a sitting position. Okay. So in sitting position, I'm looking for patellar tracking and extensor mechanism. So if you can get you to lift your hang up. So I'm looking for patellar. If it's tracking in midline, in mal-tracking situation, the patellar may be doing a reverse J sign where it disengages trochlea and comes to like laterally. I would repeat the same thing with grabbing patella between my fingers. That gives me idea if there's any patellofemoral crepitus, and in big knees when you can't see patellar tracking well, it gives you some idea how the patella is moving. Take for me. And drop it down. And do it again, please. And down. Okay, once patient is lying comfortably in the couch, always start by asking patient if it hurts anywhere, because you want to avoid areas of discomfort or tenderness, otherwise you lose patient confidence. Does it hurt me?
No.
Okay, let me know if it hurts. Okay, so I'm going to have a look at your knee, and then so most of the time you would of course start with a normal knee and go into normal knee. So always worthwhile comparing the two knees. So for this examination sake, we're just focusing on the left knee. Okay. So the first thing, of course, is always look, feel, touch. We're looking at whatever we see from standing position, confirming any wasting, any swelling, any knee effusion. And the first thing to look if there's any knee effusion is these parapatellar gutters. If you get fluid, these gutters would be full. Instead of concavity, there would be convexity over there. So we're looking for those. Okay. Any redness around the knee, you'll be looking for that. Any circulatory changes, any skin changes, that would be looking. So continuing with the feel, if you start looking for tenderness, you need to have a method to look for and identify each area around the knee where you're looking for tenderness. You need to keep surface markings of all ligaments and joint in your mind, because you are trying to identify specific pathology. Okay, when you're looking for tenderness, you need to identify the surface marking of the structures around the knee joint and look specifically for tenderness for those structures. If you're looking for MCL, it goes about 4 finger breadths below the joint line, and you want to start, if you're looking for tenderness, superficial MCL way below knee joint. Okay, and to reach the joint, the best way is to slide your finger up, and as you hit the joint, you get the dip, and then you feel for the medial meniscus along the joint, and then you can carry on feeling for the MCL tenderness with the femoral attachment. Along the same time, you can feel for tenderness around the medial patellofemoral ligament, medial border of patella, extensor mechanism, patellar tendon, tibial tuberosity. For the lateral joint line, again, follow the the tibia, and as you get the dip, that takes you to the lateral joint line. And for lateral collateral attachment, feel for its femoral attachment and its attachment on the fibular head, and you feel for any discomfort on proximal tibiofibular joint. All through the examination, we're looking for tenderness. Keep looking at the patient to see any sign of discomfort while you're doing the tenderness. So next thing that you want to see is if there's any effusion or fluid in the knee joint. If there's a small amount of fluid, the best way to find out is squeeze the suprapatellar pouch, and then as fluid moves into parapatellar gutters, squeeze it from medial side and then swipe on the lateral side, and fluid would now swipe and come out to the medial side. So what we're doing is squeezing suprapatellar pouch, emptying medial gutter and swiping lateral, so that the fluid then relocates back on the medial side and we see a bulge forming over there. That's the maneuver we do. If there's a more fluid and the knee is not into fixed flexion deformity, you can do a patellar tap maneuver, and you try to ballot patella against femoral condyle. If patients have a fixed flexion deformity, that may not work because patella would be lying firmly against trochlea and you won't get patellar tap. If there's a larger amount of fluid, usually the fullness comes up to the suprapatellar pouch, and you will get swelling comes up to 4 finger breadths proximally to patella, okay, and you will get to fullness fluid up to over there. To assess for patellar femoral joint, you want to push patella medially, see how far you can translate it medially. Feel for retropatellar tenderness on medial facet. Push patella laterally. Feel for retropatellar tenderness on a lateral facet and see how far you can translocate patella laterally, and look for any apprehension if patient has any apprehension as you attempt to sublux patella laterally, which would be a sign of patellar instability. At the same time, you want to see for any increase in Q angle, which gives a assessment of how patella may be deviating from the center. So, after we've done the feel part, then we move on to the movement, and best to compare from the normal side. So Scott, can I get you to lift your leg up straight up and bend your knee, pull your heel back as far as you can. Okay, if you keep your foot over there and do the same. So you look for any increased hyperextension, pull your heel back and you see if there's comparable movement on the two sides. And if there is any restriction of movement, you can push it further passively and see if you can get further movement, but all at the same time look for any signs of discomfort. Okay. You can, when you're looking for movement, also assess for any hyperextension, which may suggest, by grabbing the toes, which may suggest any any posterolateral corner injury. Scott has actually slight fixed flexion on the other side where he has a tibia fracture. Okay. Once you assess for movement, the next is assessing for ligaments, and especially in a painful knee, it can be sometimes difficult to assess for ligaments. To assess for collaterals, it's best done in about 20 degrees flexion. Support your hand on the lateral side, other hand on your medial side of tibia, and for a MCL, give a valgus stress, and repeat the other side for a varus. And there is a normal degree of lateral laxity. That's normal. What we're looking for is a firm end point. You compare this from other side always. If you have some degree of laxity, it's always best to repeat the same test with knee in extension to see if there's any joint opening with knee in extension. If there's a joint opening in extension, that suggests a significant degree of knee collateral and posterior capsular injury. So he does not have any opening with knee in extension. Okay. You can stop there. Once we've done that, we go on to the ACL, cruciate, anterior cruciate ligament, and that's best done with knee in slight flexion. So this is the Lachman test. In a big knee, it's best to support the thigh on your thigh, support the femur, and grab the tibia and look for forward translation of tibia. And we're looking for a firm end point besides anterior translation. If there's a firm end point, you're unlikely to have an ACL injury. Yeah. Okay. Next is PCL, and for doing that, which is there, I'm looking for posterior sag of tibia. Okay, if I put my finger on proximal tibia, normally it stands proud about 1 centimeter from distal femur. If there's a posterior sag, my finger would be touching the distal femur, and if there's a severe grade 3 sag, it may be further back posteriorly. Okay. Sometimes if patient has posterior sag, you want to make sure that when you do it, you can give a false positive for ACL because you're getting excessive anterior translation, and make sure what you want to do, your starting point is what's called neutral position. Make sure hamstrings are relaxed, get the leg up, put the leg up, get in neutral position and see if there's any excessive movement. So this is an anterior draw test, but you can be false positive if the leg is already sagging back posteriorly. In this position you can check for rotation to give some idea of the rotary stability. We don't normally do McMurray's test. It's not that sensitive, but conventional McMurray's test for medial side is valgus, external rotation, get the leg up, feel for pain, look for pain or any clunk, and repeat that for the other side. And you finish this test or the examination by rolling hip to see any hip movement or restriction of movement, and checking for sensation. You can feel me okay?
Yeah.
And circulation. Okay. So in certain specific situation, we're looking for posterolateral corner rotation abnormalities, and that we do is getting your knees patients together in prone position. I'm looking at feet, and I'm looking for increase in external rotation. And if somebody has posterolateral instability along with PCL injury, they get increased external rotation on foot on one side compared to other. And if you do it at 90 degrees, that gives you more information. So you do it at 30 degrees and 90 degrees.